Impact of Rheumatological Drugs on the Heart by Pramed Rashdi Alagami Radwan, Professor of Rheumatology, Sohag University. Introduction. Rheumatological diseases such as rheumatoid arthritis, RA, systemic lupus erythematosus, SLE, and systemic sclerosis are often associated with increased cardiovascular morbidity and mortality. While the systemic inflammation intrinsic to these disorders plays a major role in cardiovascular risk, the medications used to treat these diseases also significantly affect cardiac function, either positively or adversely. This article explores the cardiovascular effects of commonly used rheumatologic drugs, offering a balanced overview for clinicians. 1. Nonsteroidal anti-inflammatory drugs, NSAIDs. Cardiac effects. Hypertension, MAIDs may lead to sodium retention and reduced renal perfusion, exacerbating or precipitating hypertension. Heart failure. Increased risk due to fluid retention, especially in elderly patients or those with pre-existing cardiac dysfunction. Myocardial infarction. COX-2 inhibitors, e.g. celecoxib, are associated with increased risk of thrombotic events, including MI and stroke. Clinical insight. Avoid long-term or high-dose NSAID use in patients with established cardiovascular disease or high CV risk. Glucocorticoids. Cardiac effects. Hypertension and atherosclerosis due to fluid retention, insulin resistance, and dyslipidemia. Left ventricular hypertrophy and diastolic dysfunction. Chronic use may promote myocardial remodeling. Arrhythmias. Electrolyte disturbances, e.g. hypokalemia, can increase arrhythmic risk. Clinical insight. Use the lowest effective dose for the shortest duration. Monitor BP, lipid profile, and glucose regularly. 3. Conventional DMARDs, disease-modifying anti-rheumatic drugs. A. Methotrexate, cardiac effects, cardioprotective, reduces systemic inflammation, which indirectly lowers CV risk. Rare toxicities, pericarditis and pericardial effusion reported, though uncommon. Clinical insight, considered safe and possibly beneficial from a cardiovascular standpoint. B. Hydroxychloroquine, cardiac effects. Conduction abnormalities. Long-term use may cause QT prolongation and cardiomyopathy. Beneficial effects, improves lipid profiles and glucose control, indirectly reducing CV risk. Clinical insight, screen patients for cardiac arrhythmias in long-term use, particularly those with other risk factors. C. Leflunomyc effects, hypertension, a relatively common side effect. Cardiotoxicity, rare reports of cardiomyopathy. Clinical insight, monitor BP regularly during therapy. 4. Biologic DMARDs. A. TNF inhibitors, e.g. infliximab, etanercept, adalimumab. Cardiac effects, worsening heart failure, especially NYHA class 3-4, may increase mortality. Reduced atherosclerosis through systemic inflammation control. Clinical insight, contraindicated in moderate to severe heart failure. Use with caution. B. IL-6 inhibitors, e.g. tocilizumab. Cardiac effects, dyslipidemia, increases LDL and triglycerides but may not increase CV events. Atherosclerotic plaque stabilization due to reduction in systemic inflammation. Clinical insight, monitor lipid profile, statin use may be needed. C. B-cell depleting therapy, rituximab. Cardiac effects, arrhythmias and hypotension, seen during infusion, rare myocardial ischemia. Neutral to beneficial CV impact in long-term control of disease activity. Clinical insight, pre-infusion cardiac monitoring is advisable in high-risk patients. D. IL-17 and IL-23 inhibitors. Cardiac effects. Current data suggest neutral or beneficial effects on cardiovascular parameters in patients with psoriatic arthritis and ankylosing spondylitis. 5. JAK inhibitors, e.g. tofacitinib, baricitinib, upadacitinib, increased risk of MACE, particularly in patients over 50 years old with CV risk factors, as per oral surveillance study. Dyslipidemia increases both LDL and HDL, unclear impact on CV events. Clinical insight, assess CV risk before initiation. Consider alternative therapies in high-risk individuals. 6. Antimalarials in SLE, e.g. hydroxychloroquine. Long-term use may rarely cause restrictive cardiomyopathy or bundle branch block. However, it offers significant cardioprotection in SLE via control of disease activity, improved lipid metabolism, and antithrombotic effects. 7. Cyclophosphamide and other immunosuppressives. Cardiac effects, Cyclophosphamide, high doses can cause hemorrhagic myocarditis, pericarditis, and arrhythmias. Azathioprine and mycophenolate, generally cardiovascularly neutral, though immunosuppression may mask myocarditis. Clinical insight. Monitor ECG and cardiac enzymes during high-dose cyclophosphamide use.